Hi, I'm Bill Zoghbi. I'm the chair of cardiology here at Houston Methodist, and it's a pleasure to have with us today Dr. Pam Douglas. She is the Ursula Geller Professor of Research in Cardiovascular Medicine at Duke. It's great to have you.
It's great to be here. Thank you.
I want to actually tell you to take a look at the grand rounds that you just did, and I think it's fascinating, Pam, because we're revisiting chest pain evaluation in the current days, and there's so much to learn. From the stress ECG now, stress functional imaging, and CT, and FFR, in so many ways. And there's some confusion in the field. And our ACC guidelines have not been updated. Is there something on the way regarding updates of ACC guideline regarding that?
Well, not that I know of. As you know, some of these large guidelines that cover a lot of territory can be very difficult to process the amount of information and come to a consensus. So it can take a long time. Our last guidelines were published in 2012. We've not had an update around diagnostic testing since then, and we've produced a lot of evidence since then. So I hope that sometime soon we will be updating those guidelines.
There's so much information that you published from the PROMISE trial. There's also so much information from the SCOT trial, and I like the approach of precision testing, if you will. That's a term that you coined. How has this information changed the way you approach patients, or at least your recommendations to approach, although they're not in the guidelines yet? Where do you think CT or CTA fits in this calcium scoring? I know it's a big thing, but is it still CT calcium scoring? Is it still mostly for the asymptomatic individual, or can we add it to the also symptomatic individual to tell us something about prognosis?
Well, the data from PROMISE and from another trial, Crescent, would suggest that calcium scoring is a marvelous way to exclude disease in people. And given that the current population undergoing testing in the United States, about a quarter of them have no disease. And I mean no plaque, no calcium, nothing, squeaky clean. And so one way to just get that 25% or maybe even 20% off the table, if you will, by doing something quick and simple and relatively inexpensive compared to other testing.
And not much radiation either.
No, very little radiation, very little cost. 10 minutes, no IVs, no contrast agents. Is actually extremely appealing. And to me, that would be more appealing than saying, oh, the event rate in this population is low, why don't we just not test? I think the reassurance that comes from a zero calcium score would be very helpful as we think about new ways to evaluate these people, because the old algorithms are chest pain risk factors, elevated Framingham risk score or Diamond and Forster score, you must test.
Yes.
And the comfort to say, even though we've come up with algorithms that predict who's going to have a negative test and not have events, having the reassurance in that particular patient that there's nothing there, I think would be very helpful to move towards a more selective use of testing, a smarter use of testing.
And the interesting thing, obviously, in the data that has been shown is the low event rate of this population. And the impact of some of the testing to risk reduce, some prevention aspect to coronary disease, which, as you could tell from your data and what we know from the nation, that blood pressure and cholesterol and so many of the risk factors are not really well controlled.
Yeah. One of the things that was, as you're doing trials, you're looking at patients that are accruing. And when we reached our first 1,000 patients in PROMISE, we had a DSMB meeting. And we spent an hour, the DSMB was absolutely fascinated with the risk profile of the patients that were coming in. And that was just, and as was I, because the risk burden is really high. The risk factor burden is really high. And it's interesting because nobody had ever studied this patient population before, really. I mean, we all see them every day in the clinic, in the office, but we really didn't know in aggregate, what age and risk burden in lifestyle choices in medication use really was out in the community. So we have a population of 5 or 8 million patients in this category every year undergoing non-invasive testing. We actually didn't even know what they looked like.
And the beauty also is looking at these data as an aggregate in the population,
Yes.
but ultimately we have to think about the individual patient. This is where personalizing the various testings that we have to do that. So you have the options of calcium scoring, functional testing, CTA, ultimately, hopefully, risk reduction of these individuals. And as you mentioned, and we knew before, almost 2/3 of this population, where the events occur are not from obstructed lesion, and it is in the large. The other question I have for you is, in the era of radiation safety, we didn't talk much about that. Where are some of the cautions? The other thing is, in PROMISE, only 20% had stress echocardiography. Should we change that ratio conceivably with maybe better training and other things, because in this population you don't have that radiation element, and then you may want to save it for the CTs, CTAs, and ultimately angiography. Where do you see some of the cautions regarding that and some of the opportunities?
Yeah, so radiation, I think, is incredibly important. And in part because of all the focus that's been on radiation, there's been a dramatic reduction in radiation exposure over the last decade. In fact, even in the cath lab, recently a paper that came out said even in diagnostic cath, the radiations are down because people are thinking about it now. And that's true for CT. As people become more familiar with CT, they're starting to do very low, even some sub-millisievert CTs with the very high
different protocols and machines,
high detector scanners. But it's also true for stress nuclear. And so people are, when we started this, there were still thallium scans and the dual isotope scans being done in the country. That's fallen by the wayside. People understand that's too much radiation, appropriately so. And you can do very low dose with new cameras, very low dose stress-only scans, which are on the order of the same radiation as a CT now. So some of our data that we had in PROMISE that showed CT having less exposure than nuclear is really historic at this point. Is really
I like the
not
stress
relevant.
only if it is a normal, then you don't have to do resting.
Right?
Exactly.
You're done.
Exactly. Stress echo, do you think they're going to be more revival of that, or is it going to be still the same here?
Well, I'm totally conflicted, as are you. And, I love looking at echo images. I get a lot out of them. In my practice, we do a full echo every time we do a stress. So we look at all the valves, we look at diastolic function. And so we get a lot of other information about their hearts.
There's a lot of value there. It's relatively underutilized, but we want to make sure that you have the proper training, because it's much more taxing on the training portion from an interpretation point of view.
And you find stuff. So in our 1,000 stress echoes in PROMISE, we had 2 myxomas, actually. And maybe that was the cause of their chest pain. I don't know. Maybe that actually was the disease that they had. But there are incidental findings on echo. Some of them are important.
So on the horizon, from all the questions that you asked today, what would be the most important for you to test and evaluate?
The thing that I really want to test, because I think the impact, the public health and the cost impact would be great, is if we can just figure out who to avoid testing in. So if we can identify 20 or 25% of those 5 to 10 million patients who are undergoing stress testing every year for suspected coronary disease, if we can take 2 million people in this country and safely avoid testing in them, we will be saving billions, literally billions of dollars a year, if we can figure that out.
And probably, hopefully, safer, because they are incredibly at low risk too. So
there should be no change in risk, right? These people don't have plaque.
So talking about the risk of imaging or interventions or various other things.
There's a risk of a false positive test in them, right? That's not zero. And so if we could figure that out, we have a lot of circumstantial data that points to the fact that we ought to be able to figure it out, but we've got no even observational data, retrospective data, to say that that's a safe route, because we've never tried it. So I would love to test that. So if I had one thing, I would think that would be
Beautiful.
fascinating. Can I put myself out of business before I retire?
Well, Pam, what a pleasure having you. It really has been fascinating. I think it's very stimulating, and I think we have a lot of work to do. I think hopefully for better outcomes and better use of our healthcare system.
All good for our
It's
patients.
great to have you.
Thank you very much.
And I want you to follow us on DeBakey Education and Dice It, and look at various interviews and grand rounds that we show on Thursdays. So great to have you.